Hi, so this is a H&P on a patient that I saw during clinicals that was admitted to ICU. So the patient presented to the ED with the chief complaint of shortness of breath, hypotension, and abdominal pain. So HPI, so this is a 43-year-old female who was transferred from Ruidoso, New Mexico for hypotension and abdominal pain. She did have a past medical history of newly diagnosed with end-stage renal disease requiring hemodialysis, diabetes, hypertension, hyperlipidemia. She reported that her abdominal pain and dizziness started approximately 24 hours ago. She reported her abdominal pain is generalized to her bilateral upper quadrants with no exacerbating or alleviating factors, and she reported it as continuous and severe, reporting it as a 5 out of 10. As far as her hypotension, she reported it as constant, particularly when going from seated to standing, and that the only alleviating factor was sitting still. Of note, she reported that approximately 36 hours prior to arrival, she had had a left renal biopsy done for further evaluation of her end-stage renal disease. As well, she had had her first dose of hemodialysis in the outpatient setting. She did not have any other symptoms. So past medical history, contributory for hypertension, diabetes mellitus 2, hyperlipidemia, and end-stage renal disease requiring hemodialysis. Family history is contributory for both parents for hypertension and diabetes. No known drug allergies, denied any past surgical history. She lived with her husband at home, have good social support, denied any alcohol, drugs, or tobacco use. Home medications include only Lantus 20 units daily and amlodipine 10 milligrams daily. Review of systems, positive for fatigue, weakness, lethargy. Cardiovascular, of course, reported orthostasis and palpitation. Lungs reported some shortness of breath. GI reported generalized abdominal pain, bloating, intermittent nausea and vomiting, denied hematemesis or hematochezia. Neurologic were positive for dizziness and some visual changes with hypotension. Other review of systems is negative. On physical exam, her temperature was 99.0, heart rate of 101, respiratory rate of 23, blood pressure was 94 over 48, and pulse was 110. On physical exam, patient appeared comfortable, frail, debilitated, dehydrated, and disheveled. HE&T is unremarkable. Lungs are clear, no wheezing, rails, bronchi, cardiovascular, irregular rate and rhythm. She did have a 2 out of 5 systolic murmur. Pulses were palpable bilaterally to upper and lower extremities. Abdomen, generalized abdominal pain to lying deep palpation, particularly to the right and left upper quadrants. Hyperactive bowel sounds. Neurologic cranial nerves were ghostly intact. She was orange times 4, no gross abnormalities. Laboratory data, of course, was ordered. Her potassium was 6.3, creatinine was 9.1, white blood cell count was 24,700, and hemoglobin was 5.2. And then, of course, we did order a stat CT abdomen and pelvis, though it was pending at the time. So at this point, with her symptoms of hypotension and dizziness and abdominal pain, the first real differential diagnosis is going to be some sort of hemorrhagic shock due to unknown source at this point. But that patient had just had a renal biopsy that was highly concerning for some sort of bleed somewhere. So pertinent positives were abdominal pain, sudden hypotension, drop in hemoglobin. Pertinent negatives, she didn't really particularly have any hematemesis, hematochezia, and also the timing. Patient had had the procedure 36 hours ago, and she'd remained hemodynamically stable, so a pertinent negative finding was relatively hemodynamically stable, although she was hypotensive. Number 2 would be severe sepsis with septic shock due to suspected infection. Again, this would be high on the differentials as she had just had a renal biopsy. Perhaps she had some sort of renal abscess develop or something similar. Pertinent positives are going to be the weakness, hypotension, lethargy, Pertinent negatives is she was really a febrile. And then the third differential is going to be symptomatic anemia of chronic kidney disease. She had just been started on hemodialysis, so pertinent positives are going to be the weakness, dizziness, and then of course pertinent history is that she had just had hemodialysis 36 hours prior. Pertinent negatives are abdominal pain and lethargy. You really wouldn't associate that with just simple anemia from chronic kidney disease. Typically that would be more symptomatic of a pathology. So subsequently her CTA came back of her abdomen and pelvis and revealed the left renal artery hemorrhage with associated peripheral hematoma. So clearly it was obvious that she had hemorrhagic shock due to a left renal artery hemorrhage. So our assessment, number one, of course, is going to be a hemorrhagic shock due to left renal artery hemorrhage. So the priority there, the plan, number one, is stabilization of the patient, transfusion as warranted, vasopressors as needed. Number two, the underlying problem is the left renal artery hemorrhage, so it needs for emergency embolization. So urology and IR were actually contacted, and patient subsequently, though, did undergo left renal artery embolization with coiling. But we would continue with monitoring CBC, Q1 hour, airway breathing, circulation, stabilization as needed. This patient was she was certainly hypotensive, but hemodynamically stable. NPO, isotonic fluid bolus replacement, stat coax, PT-INR, insert Foley to monitor for output. Although this patient was in-stage renal disease now on hemodialysis, we still would want to monitor for any hyperperfusion, renal hyperperfusion and shock, and continue monitoring airway breathing, circulation, and transfusions until the patient was hemodynamically stable. Other chronic problems, acute and chronic renal disease with acute hyperkalemia. Of course, the plan there would be immediate hemodialysis and nephrology consult, checking CBC, CMP and AM, diabetes mellitus 2, start patient back onto Lancis and an aggressive insulin sliding scale, hypertension uncontrolled due to renal failure, start patient on IV Presolin for now. At this point, though, she was hypotensive, so no intervention would be really needed at this point, and continued close ICU monitoring. Thank you very much.